So the material contained within the slides is actually quite heavy, so I'll be dividing the recordings that are based on the slide into two. So the first part of the recording is going to be based on pharmacokinetics, and if you look at the word, pharmaco refers to drugs, kinetics refers to movement. So pharmacokinetics is a study of drug as it moves through the human body. Pharmacodynamics is basically the effects of the drug on the body, and so this is generally what we call the therapeutic effect of the drug, or the toxic effect, or the adverse effects of the drugs. All right. So pharmacokinetics can be divided into 4 different processes. So the first process is absorption. And again, if you actually click on the panel that has the word absorption and hit delete, it'll actually reveal the panels underneath it. So the first part is absorption. And absorption is the movement of the drug from the site of administration, whether it be orally via the GI tract or via some other route of administration, IV, IM, sub-Q, topical, and all that kind of stuff. So the movement of the drug from the site of the administration into the systemic circulation. And that's because most of the effects of most drugs is based on the availability of a drug through the systemic circulation as it gets to the second process, which is distribution. So distribution is when it's in the systemic circulation and it actually goes through the whole systemic circulation and can go through to different parts of the body, primarily to the target site. So you've got distribution to the target site, which has its therapeutic action, possibly to sites which leads to its adverse effects, and then to different organs in the body, namely the liver that's involved in metabolism and the kidney that's involved in excretion. So the liver is the main organ of metabolism and the kidney is the main organ of excretion. And we'll talk about each of these 4 processes as we continue on in this lecture. So, first of all, in order for drugs to move from one part of the body to the other, they generally have to go across the membrane. Now, if you remember, the cell membrane is made out of 2 phospholipid bilayers, and they form the cell membrane here. And so, as I said, for drugs to move from one part of the body to the other, they often have to go through cells. So there are 3 main ways that drugs can actually travel across the membrane. The first one is direct penetration across the membrane. So you have a drug here and it goes straight through. Now, drugs that are able to do that tend to be lipophilic because the cell membrane is made out of lipids, right? If the drug is polar or ionized, in other words, if they are hydrophilic, what happens is they cannot pass through the cell membrane without help. And so what they need is they generally need either channels or pores. And you can see here, this is an example of a channel or pore. And you can see that the channel or pore is made out of protein. It's an integral membrane protein. And what happens is when the pores open, it allows substances to go through, right? When they're closed, the substances can't actually go across the membrane. A third way for drugs to cross from one side of the body to the other would be with the help of transport proteins. And so again, you can see here, this is a transport protein. You can see it's another type of integral membrane protein. And you can see over here, this molecule is transported from the extracellular fluid outside the cell into the cell. All right. Most drugs lack transport proteins to help cross all the membranes that separate them from the sites of action, metabolism, and excretion. And so what happens is they have to work via some other mechanism, which we'll talk about when we get to the pharmacodynamics part of the lecture. Now, in terms of transmembrane transport proteins, the most common ones are called P-glycoproteins. And what P-glycoproteins do is they transport a huge range of drugs out of the cells. So when you look at where they're located, in the liver, the P-glycoproteins transports drugs out of the hepatocytes into bile so that it can be eliminated via the small intestine. In the kidney, it pumps drugs from the peritubular capillaries into the tubules, so that it can actually form urine for excretion. In the placenta, it pumps drugs out of the fetal circulation back into the maternal circulation. In the brain, it pumps drugs into the blood out of the brain. So it limits the access of drugs that enter into the brain. So again, these are the three ways that drugs can go across the membrane. The first process of pharmacokinetics is absorption. So I'm going to talk about absorption and then two other concepts that are relevant to this. So absorption, as I said, is a movement of drug from its site of administration across body membranes into blood. The rate of absorption, so how much actually makes it into, how quickly it makes it into the blood, will determine how quickly the effects will begin. And then the amount or percentage of absorption of drug from the site of administration into the blood will determine how intense, how big the effects are. So a couple of terms to do with absorption are chemical equivalence and bioavailability. So let's take this. Say you have drug X, and drug X comes in a liquid form as well as in a tablet form, right? And in the liquid form and tablet form, say there's 100 mg of the drug. So whether you take the drug as liquid or tablet, they are chemically equivalent. So the difference is this. Say, and let's say instead of a tablet, let's say it's enteric coated. Right, just enteric coated tablet. Okay, and so what happens is that a person takes drug X as a liquid, and what happens is through some processes, not all of it gets absorbed. Right, so maybe 60% of the liquid drug X actually makes it into the systemic circulation. However, if you take it in a different formulation, enteric coated tablet, say 80% of 100 mg of the tablet that you take actually make it into the blood. And so even though these two preparations of drug X are chemically equivalent, because for each the dose of the drug is 100 milligrams, when you take it as a liquid form, only 60 mg makes it into the blood. When you take it as an enteric coated form, 80 mg make it into the blood. So these two preparations don't have the same bioavailability, right? So bioavailability is the extent of drug absorption from the site of administration into the blood. Let's go on and look at this. So in the blood, what happens is eventually, in order for the drug to actually have its action, so I'm looking at the diagram on the top right panel, the drug actually has to leave the capillaries, right? And in most parts of the body, there are gaps within the capillary endothelium that allows drugs to go through. And this is how ionized or polar drugs, hydrophilic drugs, are able to leave the blood and enter into the tissue, right? And you can see here that polar drugs cannot go straight through, whereas lipid-soluble drugs, lipophilic drugs, can actually either go through those gaps or it can go straight through the membrane, the endothelial membrane of the capillaries. So some factors affecting drug absorption are the rate that the preparation is dissolved, especially important for orally administered drug. So if you've got enteric coated tablets versus liquids versus tablets, just normal tablets, the liquids are more quickly absorbed. The tablets need to be broken down. The enteric coated tablets are coated so that it can actually stay intact in the stomach, where it's got a very, very acidic pH, and then be broken down once it gets into the small intestine. So as I said before, These three preparations may contain the same amount of drug, so may be chemically equivalent, but the rate and extent of absorption and therefore bioavailability may vary because of the different absorptions and the different rates of dissolution. We're going to talk about how routes of administration affect drug absorption later on. The other thing is that drug absorption is also dependent on the amount of blood that flows in through that portion of the body that the drug is being administered, as well as the surface area around which the drug is being administered. So obviously the higher the blood flow, the greater the absorption, as well as the higher the surface area, the greater the absorption and the faster the absorption. Whether or not a drug is lipid soluble or water soluble will determine how easily it gets across the membrane. So we'll talk about that later on. And then the last thing on this slide is a concept called pH partitioning or ion trapping. And this is a very, very useful property when a drug needs to be excreted quickly because of maybe the drug reaching toxic levels, and the drug is either basic or acidic, right? So what happens is you can actually manipulate the pH of the urine. So what happens is this. So you've got the urine, right? So you've got the tubules over here, and then you've got the peritubular capillaries, which is the blood flow in through the tubules. And so what happens is if you give an acidic drug and you want to get rid of it, what happens is you make the urine basic, and so it forces the drug to go into the urine, because acidic drugs, as it says here, tend to accumulate on the alkaline side. If the drug is basic, what happens is you can manipulate the urine so that the urine becomes acidic, and so again it drives the movement of the drug to accumulate on the acidic side, right? And so it drives the a faster rate of excretion, and so there's less drug for less time in the body. So I'm going to show an example of ion trapping or pH partitioning by using the example of the effect of acetylsalicylate, aspirin, in the stomach. So acetylsalicylate can be ionized. It's an acidic drug. And so you see over here, the pH is very acidic compared to blood plasma. And so if you look at the direction of the arrows here, acetylsalicylate tend to accumulate in the non-polar form, right? Non-ionized form. Because you can see here the arrow that goes up towards the non-polar form is much bigger than the arrow going into the ionized form. And when it is in a non-polar or non-ionized form, it can easily cross across the membrane, right? And so what you see here is the non-polar form can cross, the ionized form cannot cross. It's trapped inside the stomach. Once it's actually in the plasma, what happens is it ionized into hydrogen ions and the non-ionized form. And similarly, this polar form cannot actually go back into the stomach. So this polar form is trapped, right? And then as time goes on, what you have is you have more aspirin going into this polar form, and you have a greater number of amount of aspirin going across into the blood. And as it gets into the blood, it gets ionized, and the ionized form cannot go back, right? And so what you have is you have the acidic drug tending to accumulate on the more basic side. So this is more basic, and this is more acidic. So to follow on, this slide basically gives you an overview about the factors that affect drug absorption depending on the route of administration. So you can see over here, the routes of administration that we'll focus on is intravenous, intramuscular, and subcutaneous grouped together, and oral. As you know, if a drug is given intravenously, there's really no absorption barrier because it's injected directly into the vein and straight into the systemic circulation. Drug absorption is instantaneous and 100%, so this route of administration is ideal for emergencies as it has a rapid onset of action. The other thing with this is you have a precise control over the amount of drug in the plasma. You can use large volumes and you can use irritant drugs if given over a long period of time. Disadvantages for this route of administration is that once it's in the system, it's very hard to extract it. So in that sense, it's irreversible. It's expensive and inconvenient and also unsuited for self-administration, as in for someone that's not trained to actually inject drugs intravenously, it's not suitable. Right, and it's inconvenient and expensive because there's syringes, there's needles, there's disposal of the syringes and needles, and the vials that the liquids that the meds are kept in, and so it's actually quite an arduous process to actually send a patient home with drugs that need to be administered IV. Because large volumes of fluid can be administered, there is a risk of fluid overload. And because there's exposure to the external environment, there's a risk of infection and embolism. Because the drug is given into the systemic circulation and it's made out of, it's water-based, plasma is water-based, the drug also has to be water-soluble. So those are the disadvantages and the profile of drugs that are given IV. If drugs are given IM or subcutaneously, again, the capillary wall is fairly easy to negotiate. Absorption rate is faster with hydrophilic drugs and slower with lipophilic drugs, and that's another advantage of drugs given IM or subcutaneously, in that you can actually administer lipophilic drugs via this method. You can also use depot preparation to actually make the drugs last for a longer time, so there is less injection needed and the drugs can actually act over a longer period of time. IM and subcutaneous administrations of drug tend to also be inconvenient, again for the same reasons that IV administered drugs are inconvenient. There's a possible discomfort level with actually administering drugs IM or subcutaneously, and there's also a potential for injury. Most drugs are given via the oral route of administration, and over here the absorption barrier is the epithelial lining of the GI tract, and then what happens in the liver before it actually reaches the systemic circulation, and we'll cover that in the next few slides. Absorption of orally administered drugs is slow and variable, and we'll again talk about that later on. But on the pro side, it's easy, it's convenient, and it's cheap, right? And therefore, because it's convenient to administer oral drugs, it's ideal for self-medication. And because there is a gap between when a person takes the drug and when it actually reaches into the systemic circulation, it can actually be removed from the gastrointestinal tract prior to it reaching the systemic circulation. So it's potentially reversible. Disadvantages of orally administered drug is that there is variability in rate and extent due to gastric emptying times as well as in intestinal transit time. So gastric emptying time is the amount of time it takes for something in the stomach to actually empty into the intestine. And if you can recall, most of the 90% of absorption happens into the intestine. And so if you slow gastric emptying, you slow the rate of absorption. If you increase intestinal transit time, you decrease the absorption percentage, because the drug it doesn't stay long in the small intestine, and so there's less drug being able to be absorbed. First pass effect and enterohepatic recirculation we'll cover in the next few slides. Orally administered drug have to go through the stomach and through the small intestine, and there might be some activation of the drugs either by gastric acid or by intestinal enzymes, and so it means that there's less active drug that actually reaches into the systemic circulation. Also potential for nausea and vomiting, and most importantly, the patient must be conscious and cooperative. Right? We all know children who refuse to swallow pills, even though they will swallow similarly sized candy, and so they're not cooperative in that sense. And again, you can't actually administer a drug orally if the patient is not conscious. There are some other routes of administration that are listed here: topical, transdermal, inhaled, rectal, vaginal, and direct administration to a specific site. And these routes of administration allow a smaller dose of the drug to be used. And because there's a smaller dose of the drug being used, there's less potential for side effects. And it can be directed to the target site where the therapeutic action is wanted. So this slide lists the major factors that affect bioavailability of orally administered drugs. The first point is basically how much time the drug and food spend in the digestive tract. So if you can recall, food goes from the esophagus to the stomach to the small intestine to the large intestine. And it's really in the small intestine that 90% of all nutrients and drugs are actually absorbed. So basically, the longer food and nutrients and drugs spend in the small intestine, the more food and nutrients actually get absorbed. So the shorter the time in the small intestine, the less food and nutrients and drugs actually get absorbed. And so that's one thing, right? So if food moves through the intestine very quickly, it's said to have an increased intestinal transit time. That means that it will actually reduce the extent that the drug is absorbed. The other thing is that when food is in the stomach acts as a reservoir, and it actually releases nutrients and drugs or what have you, the contents of the stomach, into the small intestine at a very, very slow rate. Now, if this gastric emptying is even slower than normal, what happens is it means that drugs will move slowly from the stomach to the small intestine, and so it will delay the rate of absorption. Okay, not necessarily delay the extent of absorption, but will delay how quickly the drug will work, because the drug needs to be absorbed mainly from the small intestine in order for it to work. Second factor that might affect bioavailability is the types and amounts of food that are found in the gut, and also whether the drug is co-administered with other drugs, right? So it might affect the absorption pattern of drugs. Third thing is special coatings on the drug prep. So we all know that some tablets and some preparations are what we call enteric coated, and so enteric coated preps have got this coating around them which actually stops it from being broken down in the stomach, and it's only when the prep actually reaches the small intestine that it gets dissolved. Sustained release preps, basically what happens is the drug is formed into granules, and again those granules dissolve over a longer period of time than would be if they were actually given just in a normal tablet. And so what happens is that the drug is released over a longer period of time. It reduces the number of doses, but it costs more and it has variable absorption, mainly because the dissolution of the granules and the release of the drugs is also variable. Tablets made by different manufacturers. So again, if you buy, say, Claritin, brand name Claritin versus buying loratadine from the drugstore, what happens is they might be chemically equivalent, but the fillers that each company uses in order to make the pill might be different, and so it might actually affect the rate of disintegration, dissolution, as well as the rate of absorption. The next two things over here I will actually explain in the next few slides. So we're going to go through to first pass effect. So first pass effect only affects orally administered drugs, and this is what happens. So as I said, 90% of nutrients and drugs get absorbed from the small intestine, and once it gets absorbed from the small intestine, it actually goes into the hepatic portal vein system, and it goes into the liver. Now, the liver, as you can recall, is the main site of metabolism. And so what happens is there's a bunch of enzymes in the liver that actually can metabolize drug to mostly break them down into an inactive form, and a form that can be more easily secreted in urine. And so what happens is drug gets absorbed, goes into the portal vein, goes to the liver, and what happens is some drugs can be metabolized in the liver before it actually reaches the general circulation. So, for example, if you take drug X and you take 100 milligrams, some drugs don't get metabolized by the liver at all, and so 100 milligrams of the drug will actually reach the systemic circulation. Other drugs, you take 100 milligrams, and the liver metabolizes 80% of the drug, and so what happens is only 20 milligram ends up in the systemic circulation. Still another drug, give it 100 milligrams, and maybe 50% of the drug actually gets metabolized by the liver, and so only 50 milligrams ends up in the circulation. And so what happens is that you have much less drug than was given in a tablet that ends up in the general circulation. And this effect is called the first pass effect. And so you can see here, there's a short little animation that you can watch just by going to that link provided there, or you can right click it. We know that alcohol is absorbed in the stomach, and so and this is also another thing, that if you eat carbs, it actually slows down the absorption of alcohol in the stomach, and so the rate of absorption slows down, and so the feeling of euphoria and getting drunk actually slows down over time. Not saying that alcohol will not get absorbed in the stomach, it just takes a little bit longer. An example of a drug that almost completely is inactivated by the first pass effect is nitroglycerin if it's given orally. So say you give nitroglycerin 100 milligrams, goes in through the hepatic portal vein to the liver. Basically around about 99% of the orally administered nitroglycerin is inactivated by the liver, and so you only get 1 milligram of nitroglycerin into the systemic circulation. And so a way around that would be to actually take nitroglycerin under the tongue, and what happens is it allows it to be absorbed directly into the systemic circulation, bypasses the first pass effect, and then it reaches the active site, the smooth muscle of the blood vessel, to actually have the therapeutic effect, to actually cause vasodilation and allow more blood to actually reach the muscles of the heart. This next thing is called enterohepatic recirculation, and again, it affects orally administered drugs only. So what happens is that, again, you start off the same way. So drugs are ingested orally, goes into the hepatic portal vein. From the hepatic portal vein, it goes to the liver. Now, in the liver, it undergoes this metabolic reaction called glucuronidation, right? And what happens is this glucuronidated drug can be more easily incorporated into bile, right? And then what happens is that bile is released from the liver here to go back into the small intestine in order for it to actually digest lipids. Right? So what happens is the liver metabolizes through a process of glucuronidation. Then the glucuronidated drug is incorporated into bile. Bile is then released into the small intestine. Right? And then in the small intestine, what happens is that there is an enzyme called beta glucuronidase that breaks the bond between the original drug and the glucuronide moiety. The glucuronide moiety is this one here. So this the glucuronidase actually breaks this bond to actually make, to return the drug to its original form, right? And then what happens is that the free drug then is then enters into the portal vein, goes into the liver. And so you can see that this cycle of event just goes around from the liver, hepatic system, to the small intestine, enteric system. And so that's why it's called the enterohepatic recirculation. Obviously, if you can appreciate what's happening over here, the drugs can stay within the enterohepatic circulation for an extended period of time. Drugs can accumulate, and also drugs don't enter the systemic circulation predictably. Because as some of it gets glucurinated, what happens is some of the drug doesn't and can actually go into the systemic circulation, but it's not predictable. Right? It doesn't enter the systemic circulation predictably. So this is called enterohepatic recirculation. Second pharmacokinetic process is called distribution. So distribution is the movement of drug from when it enters into the systemic circulation to where it actually goes into the target tissue. Okay, so a few things actually determine the speed of distribution, and one of the things that determine the speed of distribution is the blood flow to tissues. So obviously the more blood flows to tissue, the more chances the drug will actually end up there. Okay, so usually normally there is a normal blood flow to tissue, so it's predictable in terms of how quickly the drug gets to the target tissue. Sometimes what happens is drugs can be bound to protein, and we'll look at that in the next slide, to form drug-protein complexes. And some tissues, for example, abscesses, actually don't have sufficient blood supply, and so if it doesn't have sufficient blood supply, it means that the drug that's actually in the blood can't actually get to it, right? Another example of an instant where blood flow to tissues decrease is when there's a solid tumor. Because with a solid tumor, what happens is that if you have a solid tumor over here, what happens is there are blood vessels superficially, but as you go deeper into the tumor, what happens is there's no blood vessel on the inside. And so what happens is the drug can't penetrate where there's no blood vessel. Okay, so the drug circulates around the systemic circulation, and at some point it reaches the capillary beds of the target tissue, and it has to leave. So what happens over here is the middle diagram over here, where you've got two types of drug, hydrophilic and lipophilic drugs. And what you can see here is at the capillary levels, there are these gaps in between the endothelial cells. And these gaps allow both hydrophilic drugs as well as lipophilic drugs to actually exit. And once it exits, it can actually reach the target tissue, the target cells over here. So those gaps allow all sorts of drugs to actually leave. And again, the lipophilic drug can actually just go straight through the plasma membrane, because the plasma membrane is of course made out of phospholipid bilayer. There are some exceptions here, which we'll talk about in the next few slides. Now, once the drug actually leaves the capillary and enters into the extracellular matrix where the tissues and cells are, what happens is some drugs actually need to enter into the cells. Right? So some drugs need to enter into the cells in order for it to have an effect. So those drugs need to enter into the cell. And again, really, it's only lipophilic drugs that can actually easily enter into the cells, unless there's a transport protein or there's an ion or channel which allows hydrophilic drugs to actually enter into the cell. But luckily for us, what happens in a lot of instances is that there are receptors just outside the cell that drugs can bind to. And what happens is when the drug here, the circle, binds to this cup-shaped receptor, it actually triggers a change inside the cell. And that change that it triggers inside the cell is effectively what the drug does. All right, so there's no need for hydrophilic drugs to actually cross into the cell for it to have an effect. It just needs to bind to a receptor for it to have an effect. And then again, just reiterating the fact that there is a difference between passage of fat-soluble drugs versus water-soluble drugs. As we said, water-soluble drugs cannot easily penetrate through the cell membrane, so they need the help of the receptor, whereas fat-soluble drugs can. The other thing with fat-soluble drugs is it can actually accumulate in fat tissue, and actually be stored there, be sequestered there until perhaps the person maybe loses weight and the fat tissue shrinks and then releases the drug. And so some lipid-soluble drugs tend to get accumulated into fat cells and not have an effect at the desired target tissue. This slide basically gives you the effect of protein binding that's found in some drugs. So there are proteins that the liver predominantly make, and the proteins that we're going to be concerned about are large proteins such as albumin, alpha-1 acid glycoprotein, and lipoproteins. So these proteins are typically too big in and of itself to actually exit the capillaries. So you see over here, it's too big to actually go through the gaps in the capillaries, right? In and of itself. So in the liver, in the kidney, where 99% of material is filtered, proteins stay in the blood. All right. So again, in other capillary beds, these proteins stay in the blood. They are too big to actually leave. Now, with some proteins, albumin predominantly, what happens is they have these sites that can bind to drug. All right, so these are drugs here, the black circles, and you can see here that this is a reversible reaction. So free drug can be bound to albumin and can actually get released from the albumin to become free drug again, right? So that's what this double-headed arrow is. Now, if you look at panel B, what you can see here is the free drug alone, drug that's not bound to the protein, is actually small enough to leave the capillary beds through those gaps, whereas drugs that are bound to the protein are too big to actually leave, right? So you've got here, these drugs that are bound to the protein can't actually leave, whereas drugs that are not bound, free drugs, are able to leave and then have their effect at the target tissue. Okay, so that's that and that. And then again, over time, what happens is that the protein then releases the bound drug to make the drug free and able to leave. And it's only the free drug that is active, because it's only the free drug that can actually leave the blood vessels to actually reach the target cells. Okay, in some instances, what happens is there is a lower than normal amount of albumin in the blood, so that's what hypoalbuminemia is. And some instances where the albumin levels drop is when a person has got liver failure, when a person's just been through a traumatic event, when a person's just been through surgery. What happens is that the the protein level will decrease. And what happens over here is that if the protein levels decrease, I'm going to just wipe out this one and this one. What happens is those drugs that would otherwise be bound to protein are then free. So this albumin has got is bound to 4 drugs. So I'm going to put 4 free drugs into the blood system. This one is bound to 3 drugs. And so I'm going to put 3 circles again. representing an increase in the number of free drug. And what happens when there's an increase in the number of free drug is that this increased free drug can actually leave the capillaries and have an effect. So what happens is that the effect of the drug increases, and sometimes it increases it to toxic level, where you have adverse or toxic effects. So some examples of highly protein-bound drugs are listed here. You don't need to know the examples right off the bat because we'll be talking about it as we talk about these drugs. And the last thing on this is basically what happens when a person is taking 2 or more drugs that are bound to protein. So what happens is someone is taking this, say the black circles are warfarin, and I'm going to put red triangles representing a second drug that's bound to protein. And what happens is if there's a second drug that can be bound to protein, it will actually compete for these binding sites on the protein, right? So it might displace some of these red circles on the proteins. And what happens is when it displaces the red circles, the black circles on the protein, is that then there's more free drug, more free black dots, and that increase in the number of free black drugs, circular drugs, means that there's more free drug that can actually leave the system. And so what happens is that the effect of the black circles actually increase, and sometimes it does it through to levels that are toxic or leads to adverse effects. And so a way around it would be to actually decrease the dose of either one or both of the drugs that are known to be protein bound. So most of the time capillaries are leaky. So most of the time capillaries look like this, where you have gaps. But in certain instances, what happens is that the nature of the capillary changes. So for example, in the blood-brain barrier, instead of having those gaps over here, you've got tight junctions here. And what happens is those tight junctions prevent drugs from actually, mainly hydrophilic drugs, from actually leaving, right? Because this is the main route of action for hydrophilic drugs, to actually leave the blood vessels. But you can see here that lipid-soluble drugs are still able to actually penetrate directly through the blood-brain barrier in order to reach into the CNS. And so some drugs, some psychoactive drugs like the opioids and marijuana and all that kind of stuff can actually go through the blood-brain barrier to have the effects in the central nervous system. Okay? But it stops a lot of drugs that would normally go through gaps in the capillaries from actually entering in. An exception is drugs that have transport system to actually transport the drugs into the brain. All right. And then the other thing is that if you look over here, the blood-brain barrier is not fully developed at birth. And so what happens is in infants and fetuses, what happens is the tight junction isn't quite all there. And so hydrophilic drugs can actually go through the leaky tight junctions in a very young child or in utero. So that's why a woman that knows that she's pregnant has to be really careful with the type and amount of drugs that she takes during her pregnancy. And this is especially true with the placental drug transfer. So again, the same sort of thing. What happens is in the placenta, there are barriers which stop ionic and polar drugs, so hydrophilic drugs, from actually entering into the fetal circulation. But you can see over here that lipid-soluble drugs are able to go through the lipid bilayer to actually enter into the fetal circulation. So again, it's very important to monitor drug intake in a pregnant woman, because you cannot assume that the drugs will not cross over into the fetal circulation. Risks with drug transfers are listed over here. So birth defects and a baby that's drug dependent. Third and fourth phases of processes of pharmacokinetics can be grouped together into elimination. So elimination is basically getting rid of active drugs, and active drugs can be eliminated either through a process of metabolism and or excretion. So metabolism is usually breaking down a more active form of the drug to a less active form, or to a form that's more easily excreted. Main organ of metabolism is the liver, and the liver has an enzyme system called the P450 system that is responsible for inactivating a whole bunch of drugs. And then at some point, the drugs need to be actually taken out of circulation, and that occurs mainly via the kidneys. So you see over here, there's 5 little panels for different types of metabolic process. So the first type of metabolic process is basically the transformation of drugs into a form that's more easily excreted in urine, right? So you've got over here, pentobarbital is converted into a form that's more polar and it's more easily excreted in urine. Phenytoin is converted into a form that's again more polar and more ready for excretion into urine, right? Again, phenytoin, this process, this metabolic process, this chlorination also increases the chance of the drug entering hepatic recirculation. All right, so this is the most common type of metabolic process in the liver. Followed by number 2, inactivation of drugs. So you can see here when procaine is administered, it's administered in the active form, and then the metabolic process is converted to a form that's not active, and so this PABA is really not active, not able to actually exert its therapeutic effect. Number 3, increase effectiveness of drugs. So a very, very good example is codeine. Codeine is not very effective as an analgesic unless it's converted into morphine, right? Some drugs are given in 4 as a prodrug. So prodrugs are not active. And what happens is it needs to actually undergo a metabolic process in order to actually activate it. And then the 5th type of metabolic process is increased drug toxicity. So an example of this is acetaminophen. Acetaminophen is not toxic to tissues, but if it goes through one of the minor pathways in the liver, it becomes, it's converted to a metabolite that's toxic to liver tissue. Right? As I said, this is a minor pathway, so most acetaminophen do not actually undergo this pathway of metabolism unless the major pathway is completely used up. And so sometimes when a person drinks a lot of alcohol, what happens is the liver enzymes is preoccupied with metabolizing the alcohol. And so if that person actually takes acetaminophen, more than a normal amount actually goes through this minor pathway, producing this hepatotoxic metabolite, which then is toxic to the liver cells. So some factors that affect drug metabolism are listed here. So you've got over here age, and in terms of age, it's the older adults as well as the very young, right? The liver function or capacity of a child 1 year old or less isn't mature, and so what happens is drugs can cause injury and toxicity. So a way around it is to reduce the amount of drugs so that it prevents injury and toxicity. Older adults, this is an example of the liver function of a healthy older adult compared to the liver function of a healthy 20-year-old. And so you can see here that in a healthy older adult, they only have 50% of the function of a healthy younger adult. And again, the weight of the liver goes down by 37% to 63% of a healthy younger adult. So again, if you have less blood flow, a smaller organ, it functions at a lower rate, right? So again, way around that would be to reduce drug doses to prevent drug toxicity and injury. Now, I said before that there's a bunch of enzymes in the liver called the P450 system. And what happens over here is that drugs can be metabolized by the P450 system, in which case it's substrate. It's a substrate for the P450 system. Or it can actually lead to the production of more enzymes. So drugs that can lead to the production of more P450 enzymes are called enzyme inducers, and drugs that are able to inhibit the production of the P450 enzymes are called enzyme inhibitors. All right. And so what happens is drugs that are P450 enzyme inducers basically increase the speed of the metabolic process. And so what happens is that there's more drug converted much quicker to an inactive state, and so the amount of active drug in the system goes down. And so what happens is if a person takes two drugs, one is a P450 an enzyme inducer, what happens is you might have to increase the dose of the second drug. Some drugs are the opposite. They're P450 enzyme inhibitors, so they basically slow down or reduce the amount of enzymes produced. And so what happens is that less enzyme is metabolized, and so less active drug is metabolized, so the amount of active drug increases. And then if the amount of active drug increases, it increases the therapeutic effect, yes, but it also increases the possibility of toxicity and adverse effects. A third thing that can affect drug metabolism is malnutrition or adequate nutrition. Because what happens is with nutrition that we ingest, it actually is involved in manufacturing these cofactors. And so these cofactors are like these pentagon-shaped things on the picture down below. And so what happens over here is that the cofactors actually need to bind in order for the active site of the enzyme to be functional, right? So the cofactors need to be bound here in order for the active site to straighten out and be able to work. And so if there's no cofactors, what happens is the active site remains distorted and no metabolism occurs. Sometimes there's competition between two more drugs, and so these drugs may be metabolized by the same enzymes. And so what happens is if you have two more drugs going by the same pathway, the rate of metabolic process for one or both drugs may be slower, and the drugs, one or both drugs, may accumulate to dangerous levels. And again, therapeutic effect increases, but also the risk for toxic and adverse effects as well. Other factors, genetic variations. We looked at this when we looked at the conversion of codeine to morphine. Will affect genetic variations can affect the levels of liver enzyme and also liver blood flow in disease states, right? So this is an example with a healthy older adult of how blood flow is affected with just a normal healthy older adult as well as liver weight. And if you actually throw in things like hepatitis and cirrhosis, that will also affect the amount of healthy liver that actually that a person has, and it can actually affect the metabolism of the ability for that person to metabolize drugs. Fourth process, excretion. Excretion is when the drug leaves the body. Main organ of excretion is kidney function. If you're not sure of a patient's kidney function, it's best determined by creatinine clearance, not just creatinine levels, right? Creatinine levels is just a one time point thing. Creatinine clearance is when a person is given creatinine and then the blood is measured sometime after that to work out how much creatinine has left the body, and so that is creatinine clearance. So that's an indication of the activity level of the liver. Some other non-renal routes of excretion, liver intestinal tract through liver produces bile, which can incorporate drugs, and the intestinal tract at the end of the day produces feces, and drugs can actually leave through feces as well. Lungs breathe out stuff, including especially anesthesia, and then other excretory glands like sweat, tears, saliva, and breast milk. Drugs can actually be excreted through these means. factors that affect renal excretion, the pH partitioning that we talked about previously. So again, if you have an acidic drug that needs to be removed, what happens is you manipulate the pH to make it more basic, so that the acidic drug will tend to go into the basic urine, and the reverse is also true. Age is a factor, so infants younger than 12 months have an immature kidney function, and so again, less drug is eliminated, so more drugs accumulates, and it increases the risk of toxicity and adverse events. This picture over here shows you again the kidney mass of a healthy older adult compared to a healthy younger adult, and you can see here kidney mass shrinks by 35% to about 65%. So again, less kidney, less ability to excrete. The other thing, the other factor that affects renal excretion is this active tubular transport. So if you look at the picture on the top right corner, and what I want you to focus on is this active transport business over here. So active transport is the movement of compounds, material, from the capillaries, so the peritubular capillaries around the tubules in the kidney, into the tubules itself, right? So once things move into the tubules, then it actually exits as urine. So what happens is that this active transport process uses these pumps, right? And these pumps can only transport a certain amount of drugs or other compounds within a given time frame. And so if you have two more drugs that can be transported by active transport into the urine, what happens is they may actually compete with each other for a seat on that active transport pump. And so that might affect the rate of excretion and the level of excretion of drugs when they're given together. What happens when kidney function is compromised? The plasma concentration of drugs increases, duration of action of drug increases, and it can actually increase to a level where it increases the risk of toxic and adverse events. All right, so some pharmacokinetic terms, just a few more slides, are listed over here. So what we sometimes do is we look at the time course of drug responses. So in the next couple of slides, there are a couple of pictures that illustrate here, but I just wanted to explain to you some concepts. So the first concept is a concept of half-life. So half-life is basically the time needed for drug concentrations to decrease by 50%. And you can see here is that it's independent of the dose, right? Drugs with longer half-life stays in the body longer and is given less often. So if we look at common over-the-counter drugs, we look at Tylenol versus Advil. You know that Tylenol on the box, it says can be given every 4 to 6 hours, whereas Advil can be given every 6 to 8 hours, right? So the half-life of Tylenol and Advil differ. And as I said, this is independent of the dose. So what happens is that this. So we have two patients, so patient A and patient B. And what happens is patient A is given 100 milligrams of a drug. Patient B is only given 10 milligrams. Okay? And after one half-life, what happens is it decreases from 100 in patient A to 50. In patient B, it decreases from 10 to 5. After the second half-life, it decreases again by 50%, so from 50 to 25, from 5 to 2.5. In the third half-life, it decreases again to 12.5 to 1.25. And then in the fourth, at the end of the fourth half-life, it decreases from 6.25 to 0.625, right? And so, so you can see here that it's independent of the original dose or of any dose, really. And so what happens is that you've got concepts of steady state, loading dose, and maintenance dose. So steady state is the time taken for a steady level of drug to actually be found in the system. And it basically is reached in approximately 4 half-lives, right? So if a drug has a half-life of 1 day, it would take 4 days for it to reach steady state. If a drug has a half-life of a week, it takes 4 weeks for it to reach steady state. If a drug has a half-life of 2 hours, it will take 8 hours to reach steady state. Okay, now the problem is this: if you have some sort of emergency situation, you can't wait 4 weeks, or you can't even wait 4 days. And so what happens is, to actually cut down on the amount of time that the drug takes to reach steady state, what happens is you give that person a loading dose. And a loading dose is a much larger than normal dose of the drug in order to actually shorten the time to reach therapeutic levels. And we'll look at this in 2 slides time. Right? And then in order for it to reach steady state. And then after it reaches steady state, what happens is you give what's called maintenance dose to actually keep the drug within the steady state level. All right, next slide is basically what happens to a drug in the blood when a single dose is administered. So when a dose is administered, at the point of administration, there's no drug in the plasma, and as time goes on, you've got a steady increase of drug as it reaches the plasma, right? So this is probably an orally administered drug, and at some point over here, you've got metabolism and excretion actually decreasing the amount of drug in the blood, right? So plasma drug concentration drops. Now you see over here there are a couple of dotted lines. The first dotted line is this, the lower one, minimum effective concentration. So anything above that is when the drug works. Anything below that, the drug doesn't work. Right? So minimum effective concentration is that sweet spot above where the drug actually has an effect. Now, the second dotted line is toxic concentration. So in this example, what happens is the drug never reaches toxic concentration. But you can imagine if the dose is much bigger, it can go up to toxic levels and then down again, right? Toxic levels is when it has adverse effects on the person. So you want to keep it within the therapeutic range, right? And the therapeutic range is anything above the minimum effective concentration, but below the toxic concentration. Now, the length of time that the drug is effective is called the duration of response. So it's when it reaches minimum effective concentration and when just before it drops down below minimum effective concentration. So this is the duration of effectiveness. All right, and plasma drug concentration is basically the amount of drug in the plasma, and it's basically also a rough measure of the amount of drug that reaches the tissues. So for example, if we're looking at drugs to reach, say, the liver or the muscle or the heart, we can't really measure the drug at that exact target site. So there's no way that we can actually extract drug from the heart muscle itself or drugs from the liver itself without actually adversely affecting the patients, or drugs from the lungs or what have you. And so what happens is plasma drug concentration is basically just a rough and ready measure of the amount of drug that is in the systemic circulation as a measure of drug that will actually reach the target tissue. This example, last slide in this recording, basically is what happens when you've got multiple doses of drugs being administered. And you can see over here that with this, you were administering 2 grams of drugs per day. And the half-life of this drug is 1 day. Okay, so let's go about this. So on day 1, we administer 2 grams. So 2 grams actually show up in the plasma. And then at the end of the first half-life, it drops from 2 to half of that, it drops to 1, right? And then on day 2, we also administer 2 grams. And so at the start of day 2, after administration of drugs, you have 3 grams in the body. After 24 hours, that 3 grams drops down to 50% of that, so you have 1.5 grams, and then you add 2 more, you give that person 2 more grams, and so it goes up to 4.5. Oh, sorry, 3.5. Right? And then at the end of 24 hours, the 3.5 drops down to 75%. Sorry, to 50%, so it drops down to 1.75%. On day 4, you give another 2 grams, and so it goes to 3.75. And then after 24 hours, it drops down to half that, so it drops down to 1.885, right? 875, and then you add 2 grams, and so it goes up to 3.875, and then it goes down to 1.9ish. You add 2, goes down to 3.9, goes after 24 hours, it goes down to 1.95 plus 2 to 3.95, again goes back down to 1.95, and then plus 2 again, 3.95, goes back down to 1.95, plus 2, 3.95. And then on day 9, that's the last dose of drug that's given. So let's look at this. So first half-life, second, third, fourth, fifth, sixth, seventh, and eighth, right? So basically what this, the blurb down below is that it reaches steady state after 4 half-lives. So we're going to do after this, right? It basically bumps around the same levels, right? So what happens is plus 2, that the 2 grams then becomes the initial dose as well as the loading dose. Right? So it takes 4 half-lives for it to actually accumulate to steady state. And by the same token, once the last dose is given, right, it goes from 3.95 to 1.95 to just under 1. So 0.95 to 0.475 to 0.2325. Okay, so what happens is you have 1 half-life. I'm going to use a different pen. You've got 1 half-life there, 2 half-lives, 3 half-lives, 4 half-lives, for it to go from around about 2 to maybe a lot less than that, right? And so what happens over here is that it takes basically about 4 half-lives for most of the body, most of the drug, 94% of the drug, to leave the body, right? So it takes 4 half-lives to actually get up to speed, and it takes 4 half-lives for most of the body to leave, most of the drug to leave the body. Now, one thing is that this is well and good for a drug that maybe have a half-life of 4 days and for a half-life of a day. And you want the drug to actually reach the patient's to reach a steady state. You have that time and luxury for the patient to reach that steady state. But what happens is that instead of days, it takes weeks, right? So what happens if the half-life of the drug is 1 week? If the half-life of the drug is 1 week, what happens is it will take 5 weeks or 4 weeks to actually reach steady state. And that's not really acceptable. And so what happens is that in this case, for these drugs, what happens is that person is given what's called a loading dose, which is a higher amount of drug than normal. So I'm just going to give it give that patient maybe 5 grams, right? And after 1 week, it drops down from 5 grams to 2.5. Okay? And then after that, I'm going to give the person 2 grams, right? So it goes up to 4.5, and then it goes down to 2.25, and then I'm going to just give it another 2 grams, right? So it basically just bumps around this. So instead of it taking 4 weeks to reach steady state, that steady state can be reached in a much shorter time, and that's much more acceptable, especially in emergency situations. All right, so I'm going to leave it here. It's a long enough recording. You've got another recording to listen to next.